Namaskar and greetings from the IAP Neonatal chapter. It is my honor to welcome you all for this anniversary edition of our webinar series Learn from Legend, an academic initiative by IAP Neonatal chapter. We started this webinar series because our annual conference IAP Neocon 2020, which was supposed to happen in Thrissur, Kerala, was cancelled because of pandemic. And our purpose was that the knowledge sharing and the teaching should go on. Fortunately, this online platform did give us the opportunity to invite various international speakers for the talks, and we had wonderful content-rich academic sessions, webinars by our renowned faculty, and which was loved by one and all. These sessions were not only attended by our delegates from our nation, but also from the various other nations, and is being appreciated by everyone, including very senior neonatologists of the nation. I'd like to thank Dr. Nandkishore Kabra, the chairperson IAP Neonatology Chapter 2020 and his team, and the present office bearer of the IAP Neonatology Chapter 2021, and especially the organizers, Dr. Manoj and his team from Kerala, who has been constantly working throughout the year with equal zeal and enthusiasm to make this webinar series a huge success. I also like to thank our speakers, our faculty from the various nations who has given us the time and opportunity to interact with them. Looking at the popularity of this for another year, I wish you all good luck, stay healthy, stay safe. Thank you.
Thanks to Learn from the Legend webinar, we have a chance to update new knowledge in newborn care. The topic today about Lisa and answer is very helpful. Give us evidence so in future we will try to do more and more non-invasive surveillance. Thank the Legend and Professor Ram for such an interesting topic. We hope we have opportunity to collaboration together with Legend. We can have more and more topic to help the doctor have a chance to raise the knowledge and practical in Vietnam.
Hi friends, learn from the legends. Brainchild of Dr. V.C. Manoj and his team is probably the most popular and highly subscribed webinar series in the recent past. I have seen them for a full year, conducting consistently and punctually all the meetings in an impeccable manner. This webinar series has given us all the opportunity of listening to the leading proponents of neonatology in various countries around the world. I congratulate NNF Kerala and the neonatal chapter of IAP for consistently and properly conducting these programs. I am sure it will not be wrong if I say that Learn from the Legends is by itself become a legend in the field of webinars and neonatal lectures. I wish the program all the best.
Hi, NNF Kerala. Congratulations on your anniversary session. Thank you for organizing excellent speakers and providing up-to-date education in neonatology. We hope you will continue to do so in the future and greatly appreciate it. Regards from Croatia.
Heartiest congratulations to Dr. V.C. Manoj and his team. This webinar series, Learn from the Legends, has been an academic feast. I'm sure it has ignited several minds. To me, this has been a great opportunity to learn, relearn, and most importantly, unlearn. Thank you very much and all the best.
Hi everyone, I am Dr. Ha from Vietnam. On behalf of Vietnamese team, I would like to say thank you to Dr. Ramanathan from USA with his Saugstad lecture for Return Baby. Now we are very familiar with the LISA technique using the nasogastric catheter. Learn from Listen in 2020 was an interesting conference. That's why we are waiting for this forum this year. Thank you.
Dear friends, welcome to one and all. I am Dr. Nan Kishore Kabra, neonatologist practicing in Mumbai. The Learn from the Legends, an international bi-monthly webinar series in neonatology that began last year on 19 June 2020 is successfully completing 1 year. This was an academic initiative of IAP Neonatology extremely popular and everyone looks forward to attending them. It has also made us aware about the current best evidence and current best practices in the field of neonatology. I have no doubt that the Learn from Legends series has taken academic neonatology to greater heights. I wish you all the very best for the future. Thank you.
I am Dr. Aldagdag Matias from the Philippines, a neonatologist trained under Dr. Victor Yu of Monash, Australia 32 years ago. I congratulate the speakers for their expertise in discussing the neonatal issues and their contribution to the care of sick neonates. Their updates and approaches to diagnosis and management measures are very practical. I practice in the countryside and I content myself with available resources. Thank you very much to NNF Kerala. Maraming salamat po.
Congratulations to Dr. Monu and his team for completing 1 year of International Neonatology webinar series, Learn from the Legend. It has been a great academic initiative by the Indian Academy of Pediatrics Neonatology chapter and well supported by Indian Academy of Pediatrics Thrissur branch and National Neonatology Forum. The program has surpassed our expectations and reached to many neonatologists across the world, and many have benefited from this. I wish the team good luck to carry it forward till the next conference next year. Thank you.
Hi, we are from Highlands, Vietnam. The Learn from the Legend webinar series is very exciting, with lots of useful topics in neonatal clinical practice. I really like the because it has a high applicability in both the present and future. I was also impressed with Professor Ramanathan and the detailed enthusiastic sharing. Thank you for organizing the meaningful webinars. We are honored to be a bridge that helps Vietnamese doctors access this program, which Learn from the Legend 2021 a great success. Stay safe and take care during this time.
Hi everybody, Ahmet from Turkey. I congratulate your team. Thank you for your all webinars. To all speakers, to all legends, to all pioneers in neonatology, on behalf of all neonatologists in Turkey.
Hi, I am Blanca Arteaga. I'm a neonatologist in Mexico, in the province of Puebla. I work in the NICU of Hospital Angeles Puebla. My daily activity is work with premature babies and newborn. I feel very happy to have listened to the most of the presentation of people so brilliant that they motivate me to continue working for the babies. Thank you for sharing your experience and knowledge.
everyone. Hearty welcome to the special anniversary session of Learn from the Legends, our international neonatology webinar series.
Learn from the Legends originated last year in June as a humble effort by our team IAP Neonatal during the pandemic days to deliver quality academic webinars, recent advances, and current concepts in the field of neonatology.
Epic series is a telling example of warm relationship between IAP Neonatology Chapter, India, National Neonatology Forum, Kerala, and Indian Academy of Pediatrics, Thrissur branch.
We have had 30 lectures so far in the last 12 months on the different aspects of neonatal care by faculties from all over the world.
As you might be aware, all our lectures are available for your future reference in the YouTube channel Learn from the Legends.
You know very well that it is very unlikely for international academic webinar series to continue uninterrupted for in a year and also celebrates its anniversary.
And it's a true honor for us, Learn from the Legends, to enter the second year and to go forward with renewed interest and increased participation from the neonatal community all over the world.
On this special occasion, we wish to thank all our legendary speakers who were the backbone of our webinar series in our journey since June 2020.
Thanks to the wonderful team of legendary faculty members and their pearls of wisdom, our webinar series was widely appreciated by all of you.
Today on this special occasion, we are thrilled and humbled to express our sincere thanks to this august group of 7,000 plus delegates from 70 plus countries who are our real inspiration to continue this effort. Tiding over this pandemic with updates is so very important to all of us.
We sincerely hope that this webinar series is genuinely helpful to the neonatal fraternity in improving the outcome of the newborn infants all over the world.
Today, we are truly fortunate to have two legends of international repute, Professor Ola Saugstad and Professor Richard Polin, who have carved a niche for themselves in the field of neonatology.
We all know that both of them are two legends whom we look up to all the time. Hearty welcome to both of you, sirs, to this session.
Before we start the scientific session, we would also wish to thank all those who have sent in their feedback to remember us on this special occasion. Thank you.
Hello everyone. Once again, hearty welcome to the special anniversary session of our Learn from the Legends. We are truly thrilled and humbled to have two of the greatest living legends of neonatology today with us. Professor Ola Saugstad from Norway and Professor Richard Polin from USA to celebrate our special anniversary session with two eloquent lectures. The first one by Professor Ola Saugstad on current updates in the delivery room management, and the second one by Professor Richard Polin on neonatal hypoglycemia, the recent updates and controversies. So, without wasting any more time, I would request my colleague Dr. Phoebe Francis to introduce the first speaker.
Ladies and gentlemen, Professor Dr. Ola Dietrich Saugstad is a Norwegian pediatrician, neonatologist, and neuroscientist who is internationally recognized for his research on resuscitation of newborn and his contribution to reduce neonatal mortality. Since 1991, he has been a professor of pediatrics at the University of Oslo and the director of the Department of Pediatric Research at the Oslo University Hospital. Dr. Ola Dietrich Saugstad is a world-renowned expert in neonatal medicine, particularly on hypoxia and purine metabolism, hypoxia and reoxygenation injury, the effect and mechanism of oxygen radicals in neonatal period, mechanism of lung injury, and neonatal resuscitation. In 2010, international guidelines for newborn resuscitation were amended based on the research of Saugstad and his colleagues. to recommend the use of air in place of pure oxygen, a discovery that estimated to save lives of 2 lakh newborn each year. He is an advisor to the World Health Organization on child mortality. Saugstad has more than 500 articles to his credit and has been heavily cited in the scientific literature. He is described as one of the most internationally recognized and mostly widely cited pediatrician of all times. Dr. Saugstad is currently the chairman of Scientific Committee of Union of European Neonatal and Perinatal Societies. He was the founder president of Norwegian Society of Perinatal Medicine. He has also served as the president, European Association of Perinatal Medicine. Saugstad received several prestigious awards as recognition for his contributions. The Nordic Medical Prize in 2012, the Martha Philipson Award for Excellence in Pediatrics, the Landmark Award of AAP USA, the Maternite Prize of European Association of Perinatal Medicine, the Saling Award of World Association of Perinatal Medicine, the Golden Amnioscope from International Academy of Perinatal Medicine are a few that needs to be mentioned here. It is my pleasure to invite Dr. Ola Saugstad to discuss his views on updating delivery room management. Over to you, sir.
Well, thank you very much, Dr. Francis, for these very kind words, and also Dr. Manjo for always being so kind to me. It's a great honor, it's a great pleasure to be re-invited back to this series and to this anniversary. And it's
the
also
honor is ours, sir. Honor is ours, actually, to have you for the second time.
Thank you. And it's also a pleasure to share this with Professor Richard Polin. So let's see if I'm able to, do you see my screen now? Do you see my screen?
Yes, sir, it's visible. Please go ahead.
Do you see my screen?
Yes, sir, please go ahead.
It's visible.
Yes, sir.
Okay, so again, thank you. And it's already a year. Yes, thank you. So my topic today is delivery room handling. So here's my outline, and she is very ambitious. So I'll see if I'm able to go through all of it during these next 40-45 minutes. Before I go on, this is my disclosures. I've received research funding from Lærdal Foundation for Acute Medicine, and I'm also serving as an unpaid and an unpaid member of Airway Therapeutics Scientific Advisory Board. Now, when you talk about delivery room handling, we're talking about the golden minutes or the golden minute. So what we are doing in the delivery room may be important for the changes we are applying to the newborn. All of these, of course, have to be evidence-based, and all of them may affect on long-term outcome. Of course, what happens in pregnancy and also before pregnancy and also postnatally is of importance, but now we will focus on what's happening during these important minutes, maybe up to 30 minutes most. So start out with showing you some quite recent data demonstrating from, just want to remove this, see if we can get this out of my site, yeah. And here is, I get an artifact here, do you see it? I'm not able to remove it, I think. Well, anyway. So this is from the European so-called e-newborn database, where we have almost 40,000 babies, less than 32 weeks of gestation. And you can see how the gestation is distributed from 22 weeks, reaching a maximum here at 31 weeks and up to 32 weeks. And here we have plotted neonatal mortality versus gestational age. And you see it's an inverse relation, because it's a very high mortality compared with 32 weeks. And here we have the odds ratio for mortality. We don't have for 22 weeks, but for 23 weeks, odds ratio for mortality compared with 32 weeks is almost 40-fold increased risk. We also know that gender, sex is important, that females are doing better than males, and also that growth retardation. Now, small for gestation age in this cohort doesn't increase the risk for mortality very much when it's defined as less than 10th percentile. However, less than the 3rd percentile is increasing the risk for death with approximately 5-fold. So here we have the ILCOR resuscitation algorithm for newborns. And I will not go into that in detail because I'm sure ILCOR introduced this term, the golden minute, the first important 60 seconds of life. There's only one problem with this definition, and that is ILCOR forgot to define when the golden minute starts. So when I travel around, I ask people, when do you start the clock? When do you start the monitoring? And I get different answers when the shoulders are, but I think it's important that we agree on the term and that we start the clock when the whole baby is out, because it's not only a matter of the golden minute, but we are recording APGAR score at 1 minute and 5 minute or so. In 2020, ILCOR published new treatment recommendations for the resuscitation of newly born infants. So together with Nikki Robertson and Max Vento, we published an overview of the most important changes from 2015 to 2020. And what was introduced, which was a new topic in 2020, was that it is important to do briefing and debriefing after neonatal resuscitation. And it is believed that briefing and debriefing may improve short-term clinical and performance outcomes, not only for the infants, but also for the staff. And this is probably not so new, but it's also stated now that for non-vigorous newborn infants delivered through meconium-stained amniotic fluid, routine immediate direct laryngoscopy is not recommended with or without tracheal suctioning, whereas immediate resuscitation without direct laryngoscopy is recommended. And in the 2020 guidelines is also against the use of initial sustained inflation. I will come back to that a little bit later, but this is now recommended against, except for in research settings. And again, this is for preterm babies, and for term and late preterm infants, again, they do not recommend any specific duration for the initial inflations. Further, what is new regarding use of intravascular access is that if you don't have intravascular access, you may administer epinephrine or adrenaline endotracheally at a larger dose than the recommended 0.01 to 0.13. So that's another new issue, is that Well, of course, they recommend umbilical venous catheterization as the primary method of vascular access. But if umbilical access is not feasible as a reasonable alternative for vascular access during newborn resuscitation. And what is also new is that if you remember the guidelines from 2005, 2010, it was recommended that if the baby had a low APGAR score or was pulseless, after 10 minutes you could stop resuscitation. Now they state that a reasonable time frame. Let's see, I have to get frame to consider before discussing ending resuscitative efforts is about 20 minutes. And it tells us that we don't know exactly when we should stop, but after about 10 minutes, we could stop if a response. So if you look at the guidelines or the algorithm, the first minute of life, what are we supposed to do during the first minute? Well, during the first 30 seconds, you should dry the baby, keep the baby warm, wrap it into plastic if it's less than 28 weeks, and you should stimulate it to breathe and position the airways correctly, and you should start recording heart rate and breathing rate. And during the next 30 seconds within the golden minute, respiratory support should be established if that is needed, and also a pulse oximetry if it's needed and if it is available. Now, is the golden minute really realistic? Are we able to do all these procedures within the first 60 seconds? Well, we published recently this very brief report where we summarize some data from different studies, and we also needed positive pressure ventilation. And this is from Tanzania, and you see here that in this study, they start in mean ventilation 2 minutes and 14 seconds. That's very late. That's far outside the gold minute. Here in Uganda, they were a little bit better. It was 68 seconds, close to the gold minute, and Nepal, 71 seconds. And again, for Tanzania, it's the same group and the same material. Quite late, 109 seconds. But this data from Uganda and Nepal demonstrate that it is possible, it is achievable to start positive pressure ventilation, if that is needed, approximately within the first minute of life. Before I go on, I would like to mention some maternal and antenatal factors which are important for the outcome of delivery room handling. And first, I would like to remind you that maternal BMI, body mass index, is of importance for the outcome. This is a study we published in JAMA, now it's 7 years ago, but I think the data is still valid. And it shows that actually all mortalities, and here we have the perinatal mortality, increases with mother's BMI, and this is the BMI at the beginning of the pregnancy. So what does it tell us? It tells us that it is important, we as doctors, we have to inform the population, especially young girls, young women, that it's important to keep the BMI within normal levels in order to reduce the risk for the baby. What about the use of antenatal steroids? Well, again, this is 95% of these babies receive antenatal steroids, but not all of them had a complete course, there was only 60%. Many of them, 20%, had an incomplete course. But when you look at how this affects the outcome, you can see that incomplete course reduces mortality almost to the same level as the complete course. So I think the message from this study is that even if you don't have time to complete the course of antenatal steroids, mortality. We also know that the mode of birth affects neonatal outcome, C-section versus vaginal delivery. And this is a figure I've adapted from Yi and co-workers some years ago. And it demonstrates that neonatal mortality is influenced by C-section and decreases, but often seem to influence mortality anymore. Of course, morbidity may be influenced, but regarding mortality, it seems that you don't gain much by increasing the C-section rate or aim at the C-section rate between 10 to 20. I mention this because I know that the C-section rate is way too high in so many countries around the world. And here I have looked at how the C-vaginal, C-section, the open bars here, and you see that 37 weeks, you have higher morbidity rate after C-section. And this goes up all the way up to 40 weeks. So there is an increased morbidity after C-section. And this we have to be aware of. Now, what is the need of resuscitation? And when we look at the European database once again, you see that so-called basic resuscitation, which is bag and mask ventilation, basically. You see that very few of the most immature babies need that, but you reach a maximum around 30 weeks. Approximately half of the babies would need basic resuscitation. However, when we talk about advanced resuscitation, which is bag and mask plus need of oxygen, plus intubation if needed, and chest compressions, adrenaline, you see that the smallest babies, more than 90% of them would need advanced resuscitation, and then it goes down like this to 32 weeks. So does it matter? Yes. It seems that basic resuscitation, the need for basic resuscitation doesn't affect mortality as shown here, but as soon as one of these babies need advanced resuscitation, mortality is increased approximately twofold. So let's continue with another, I think, an important topic. How should we assess the heart rate at birth? And there has been a lot of discussion about that, especially after ILCOR in 2015 suggested that the heart rate immediately after birth should be determined by ECG. We know there are several methods to determine heart rate by palpation of the cord, stethoscopy, and pulse oximeter. Here is a study from the Netherlands where they found Vonderen and co-workers. They compared heart rate, is a green here by ECG versus pulse oximetry, the blue. And you see that pulse oximetry underestimates the heart rate, especially the first 2 minutes after birth. And here is a study by Camlin and co-workers from Melbourne, showing that compared auscultation and palpation versus ECG, and both of these methods, they underestimate the heart rate, palpation more than auscultation. So heart rate by auscultation is inaccurate and underestimates the heart rate obtained by ECG. But together with Roger Sol, we argue that if we count heart rate 10 seconds instead of 6, which is recommended, much of this inaccuracy could be eliminated. It seems that a reliable heart rate is obtained earlier with ECG than with pulse oximetry. In one study, the difference was 84 seconds, which is quite a lot. It's almost 1.5 minutes. On the other hand, 30 to 40% of ECG signals are excluded in some studies due to technical problems. And it has been shown in animal models by Schmolz's group in Canada that pulseless electrical activity is found up to 50% in animal asphyxia models. But we are waiting for newer devices to be developed, for instance, based on Bluetooth technology. But Roger Sol and I, we will still argue that auscultation is still the gold standard for assessing heart rate immediately after birth. Now, suctioning or not, when I started as a resident, we suctioned more or less every baby we were treating where we were in the delivery room. But we know that Ilkor already 10 years ago recommended that routine interpartum oropharyngeal and nasopharyngeal suctioning for infants born with clear or meconium-stained amniotic fluid is no longer recommended. And the reason for that is based on data from this study and others showing that if you suction babies routinely, the oxygen saturation is decreased, and in this case, up to 6, 7, 8 minutes after birth. And these are from vaginal deliveries, but similar data have been presented after C-section. Well, I mentioned sustained inflation already, and I will not spend much time on that, but there was a Cochrane review recently showing that sustained inflation was not better than intermittent ventilation regarding mortality and need for intubation, need for or duration of respiratory support or bronchopulmonary dysplasia showed no evidence of relevant benefit for sustained inflation over intermittent ventilation. However, the duration of mechanical ventilation was shortened in the sustained inflation group, but the authors of this Cochrane review, they say that this result should be interpreted cautiously as it can be influenced by study characteristics other than the intervention. So we need more studies. And as many of you know, the so-called SAIL study was stopped due to adverse effects, higher mortality in the sustained inflation arm. This study has now been published in full in, I think, New England Journal of Medicine. Now, the SAIL study included babies between 23 and 26 weeks, requiring positive pressure ventilation in the delivery room. And here's the protocol. There are 2 long ventilations, initial ventilations, so 20 seconds and 25 seconds. What I found was that early death was increased significantly in the sustained inflation group. So this study was stopped prematurely. You see here, mortality is 7.4% in the sustained inflation group versus 1.4% in the IPPV group. Now, cord clamping, and we have heard a lot of cord clamping the recent years, and here are some of the recommendations. And you see most societies and bodies now, they recommend delayed cord clamping. And if we look at how much blood is transfused during the first 2 minutes after birth in healthy, this is from healthy term babies. And you see here that this is the percentage of the total volume at the y-axis. And you see at the 60 seconds, 70% of the blood has been transfused. And this is the reason why many of these recommendations say that delayed cord clamping means that you should wait 60 seconds. It's not so much to gain if you wait more than 60 seconds. But there are many factors that are playing a role for during cord clamping, and it's whether or not you started ventilation, before. And I just want to point out here, this is a little bit busy slide, but you see here that if you delay cord clamping, you see this is how the oxygen saturation, I'll come back to that, how it increases the first 10 minutes of life. And you see that if you delay cord clamping, oxygen saturation increases faster compared with immediate cord clamping. Now, recently, systematic review and meta-analysis was published by these authors, Fogarty and co-workers from Australia, and they looked at babies less than 37 weeks. They were able to identify 19 trials where investigators had compared delayed cord clamping, defined as 30 seconds or more, versus immediate cord clamping. They had almost 3,000 babies. Now, delayed cord clamping reduced the relative risk for hospital mortality by 32%. Number needed to benefit, 33. And the grade quality of evidence was high in this study. Now, an issue which I know is discussed a lot now is should we resuscitate with an intact cord instead of clamping the cord immediately? Now, Kateria and co-workers from San Diego, they carried out a randomized trial on this recently. And here we see that the infants were randomized to be delivered with delayed cord clamping and resuscitation and delayed cord clamping only. Now, this is a very busy slide summarizing a number of hemodynamic variables, and I will not go into detail, but what you can see here is that there's absolutely no difference between these groups. So these authors, they concluded that ventilation plus delayed cord clamping is feasible, but in this case, it did not lead to any measurable clinical improvements immediately after delivery or reduce subsequent neonatal morbidity. Caretakers should consider providing adequate stimulation before cord clamping. Now, a very recent paper, which I found interesting, came out in April from Heike Rabi's group. And what they were underlining was a new aspect, for me at least, was that blood transfusion, as happens with delayed cord clamping, that it widens the vascular lumen, as demonstrated here, and that activates endothelial liver cells. And by such activation, there's a release of angiocrinic signals and a number of factors illustrated down here, but I'll not go into detail. But according to these authors, this enhances proliferation and survival of hepatocytes. And this may be one mechanism why the prognosis is better after delayed cord clamping. Are there any risks for delayed cord clamping, as overtransfusion, symptomatic polycythemia, jaundice, hypothermia, persistent pulmonary hypertension, delayed resuscitation? Well, this has been discussed by Bruckner, Kateria, and Schmelzer very recently. You see, this is a very recent paper. And they conclude that delayed cord clamping in healthy term infants for at least 60 seconds should be practiced in high resource environments, and they say for at least 180 seconds in limited resource environments. And delayed cord clamping reduces incidence of anemia and iron deficiency. It improves hemodynamic parameters, and there is no evidence, according to them, that delayed cord clamping results in higher rates of phototherapy. What about growth retarded children and monochorionic twins? Well, these authors say that we need more evidence before we can give strict recommendations. And as many of you know, today, many are practicing so-called physiological cord clamping, that we don't cut the cord until we start ventilation. And this is based on a study, several studies, but one study, this from Stuart Hooper's lab in Melbourne, showing on newborn lambs that if you clamp the cord before ventilation, you see that the blood pressure increases like this, and also the carotid arterial blood flow jumps up like this. By contrast, if you ventilate before you clamp the cord, you get this smooth transition here. Here's the blood pressure. It doesn't hardly change at all, and also the carotid blood flow, you see that. What about cord milking? When you, for instance, cut the cord at about 25 centimeters from the umbilicus, and within 30 seconds, you milk 3 or 4 times towards the baby at the speed of, for instance, 10 centimeters per second. Well, there are a number of studies now summarizing the effect of cord milking versus early or delayed cord clamping. And this is a meta-analysis including 19 studies, more than 2,000 babies. This is from Australia also. It demonstrates that delayed cord clamping improves outcomes in comparison with early cord clamping and umbilical cord milking. Umbilical cord milking versus early cord clamping reduced the risk of severe intraventricular hemorrhage, and the relative risk is 0.69. This was published last year. And a very new study by Seidler and co-workers, also from Heike Rabi's group. There's another meta-analysis with including 42 randomized clinical trials, more than 5,000 preterm infants. And they found that delayed cord clamping and umbilical cord milking versus early clamping slightly improved survival, but relative risk only 1.02, only 2%, and without affecting the risk of severe intraventricular hemorrhage. So delayed cord clamping and umbilical cord milking, according to this study, present similar risks of severe intraventricular hemorrhage, and relative risk is 0.60 here. And another very new study from Yassani and co-workers, a meta-analysis including 56 studies, and now is almost 7,000 infants, preterm infants, found that delayed cord clamping versus early decreased mortality, odds ratio 0.64, and also the risk of intraventricular hemorrhage, 0.73. Umbilical cord milking versus early cord clamping decreased the risk of intraventricular hemorrhage, while there was no significant difference between umbilical cord milking and delayed cord clamping for any of these outcomes. So there are a number of very recent studies. This is the study from Katera and co-workers showing that for babies between 23 and 27 weeks, there was increased risk of severe intraventricular hemorrhage. And I think this is the main reason why umbilical cord milking is not recommended presently. So what happens when you're milking the cord? It's illustrated. This is Satyan Lakshmin Rushima's drawing, excellent drawing. So here is the milking, and you see that this leads to an increased venous return to the right atrium, and the blood enters the persistent foraminal valley and up in the aorta. And because there's a pulmonary vasoconstriction, there's also a lack of cerebral autoregulation, and there's a right to left ductal shunt. This results in fluctuations in flow to the immature brain, which has fragile germinal matrix, and this may induce intraventricular hemorrhage. So what do ILCO say about this early versus late cord clamping or cord milking? Well, in 2020, they stated that for preterm and term infants who do not require resuscitation at birth, it is reasonable to delay cord clamping for longer than 30 seconds. For term and preterm infants who require resuscitation at birth, there is insufficient evidence to recommend early cord clamping versus delayed cord clamping. And regarding umbilical cord milking, they warn against, they do not recommend cord milking for babies less than 28 weeks of gestation. Now, very recently, only 4 or 5 days ago, Dani and coworkers from Italy had this viewpoint in JAMA Pediatrics, considering an update on umbilical cord milking for the new guidelines for neonatal resuscitation. And they stated that since most infants born very preterm need resuscitation, virtually none of them may have the potential beneficial effects of delayed cord clamping, although this strategy has been found to decrease mortality in infants born at 28 weeks gestation or less. Guidelines recommend avoiding umbilical cord milking, and these refer to a single randomized clinical trial by Kateria and coworkers. And this study found that severe intraventricular hemorrhage, grade 3 or more, was significantly more frequent, 22% versus 6%. I showed you the data for babies between 23 and 27 weeks in comparison with those who had delayed cord clamping. However, this study did not include a control group assisted with the current standard of care, namely early cord clamping. So what it actually demonstrates is that delayed cord clamping is more effective than umbilical cord milking in preventing severe intraventricular hemorrhage, but not that umbilical cord milking is less effective or more dangerous than early cord clamping in infants born preterm and full term who need resuscitation at birth. So these authors, they now say that maybe we should reconsider the recommendation against umbilical cord milking for babies less than 28 weeks, because they say it's not based on evidence. And I think they have a point. So I guess that maybe the last word has not been said about umbilical cord milking in the most immature babies. And now I will switch on to a few words about oxygen. And I know I've talked about oxygen previously, but I'll give you some new data, I think. And one of the most burning questions now in neonatology is which FiO2 should we start on with in the delivery room in immature babies in need of positive pressure ventilation in the delivery room. So we carried out a systematic review and meta-analysis published in 2017. Babies less than 32 weeks who were resuscitated with initially with a high FiO2, we defined that as 60 to 100% versus a low FiO2, 21 to 30% oxygen. And when we looked at primary outcome, which was death, there was absolutely no difference whether you start high or low. Julia Owie from Sydney, she was the principal investigator of the so-called Torpedo trial. In this trial, babies less than 32 weeks who needed positive pressure ventilation in the delivery room were randomized to 100% oxygen or air. And in the whole cohort, there was no difference in mortality whether you started high or low. However, what was found in this study was that those babies who had not reached a saturation of 80% within 5 minutes, they had a higher risk of death or disability. So if you reach a saturation of 80% or more, this primary outcome was in fact reduced 50%, as shown here. And when we did a follow-up of these babies, published some years ago, Tamrin and co-workers, we also saw that the babies that reached a saturation of 80% or more within 5 minutes, they had a higher cognitive score, 5 points higher which I think is quite substantial. And those babies who did not reach a saturation of 80% within 5 minutes, they had also more severe interventricular hemorrhage and also higher mortality, but there was no effect on BPD. So for that reason, we became very interested in how should saturation develop the first few minutes after birth. So here we have the so-called Dawson nomogram showing how saturation develops in term babies after a normal delivery. And you see here is the median value, and here's the 97th percentile, and down here the 3rd percentile. You see this wide variation in saturation, and it starts low and it increases. But what you see in median, it takes 2.5 minutes for these babies to reach a saturation of 80%. Excuse me. And for babies between 32 and 36 weeks, this is 3.2 minutes, and for babies less than 32 weeks, it's 3.6 minutes. Now, it's not only the gestational age, which is of importance for how the saturation develops the first minutes after birth. It's also whether you use CPAP or not. So here, Max Vento, he has plotted how saturation develops the first 10 minutes of life in babies less than 32 weeks who were on CPAP, and compared with the Dawson curve, babies were not on CPAP. And you see that if you are on CPAP, you reach the saturation of 80% approximately 1 minute earlier than if you're not on CPAP. And there's also a sex difference. Girls reaches a saturation of 80% approximately 1 minute earlier than boys. And we also know, as I mentioned already, that cord clamping plays a role. If you clamp the cord late, you reach a saturation of 80% earlier than if you clamp the cord early. And this is a very recent study from Max Vento's group, where he compared the development of saturation in his own cohort, where they practiced delayed cord clamping and compared it with the Dawson curve. And what you see here is that you reach a saturation of 80% substantially earlier when you practice delayed cord clamping. So one of the important questions, as I mentioned, in neonatology today is whether you should start with a high or a low initial FiO2 in the most immature babies. To examine this, Dekker and co-workers from the Netherlands, they randomized babies between 24 and 29 weeks who needed positive pressure ventilation in the delivery room. They were randomized to receive either 30% oxygen or 100% oxygen. And they adjusted the FiO2 according to the saturation. What they found was that the babies who had been ventilated with 100% oxygen, they had a higher minute volume, shorter duration of mask ventilation. They had a higher oxygenation at 5 minutes, which is not surprising, but they had a shorter duration of hypoxemia and a higher FiO2 exposure during the first 5 minutes. There's no difference in duration of hyperoxemia and oxidative stress markers. Now, I have now compared the Dekker, the development of the saturation in the Dekker cohort with a cohort followed by Owe and co-workers, babies less than 29 weeks. Both cohorts were started with 30% oxygen. And what you see here is that the Dekker babies, they start much lower than the Owe babies. It takes 5 minutes before they catch up with the OV babies, although they start with the same FiO2. I think this illustrates that maybe as important as which FiO2 you start out with is how you adjust the FiO2. And here I have compared data from Julie Ovi. These are babies less than 29 weeks who were resuscitated with 100%, 90 to 100% oxygen, the red line, and the blue line, those who were resuscitated with 30% oxygen, compared with Decker, the yellow here, those who resuscitated with 30%, and those who resuscitated with 100%. And as I mentioned already, those who were resuscitated with 30% start much lower than the OV babies. And in fact, the OV babies starting with 30% oxygen has the same saturation at the first minutes as the Decker baby started with 100% oxygen. So again, I would like to emphasize that as important as which FiO2 you start out with is how you adjust. And I mention this because I think it is important to start as low as possible. Then a few words about chest compressions before I end. And I think there are several questions regarding chest compressions and oxygenation. And here are two of them. Which FiO2 should we apply during chest compressions? And should FiO2 be weaned rapidly or gradually when reestablishment of circulation is achieved? ROSC. Well, according to the NRP, they state that it may be reasonable to increase inspired oxygen to 100% if there was no response to positive pressure ventilation with lower concentrations. Once return of spontaneous circulation is achieved, the supplemental oxygen concentration may be decreased to target a physiological level based on pulse oximetry to reduce the risks associated with hyperoxia. So which FiO2 should we apply during chest compressions? Well, in a study by one of my previous fellows, Anne Solevåg, we didn't find any difference in the time to reestablishment of circulation, the number of epinephrine doses, carotid artery blood flow, saturation of PO2 during chest compression, whether you start with 21 or 100% oxygen. There was a higher PO2 immediately after establishment of circulation in the 100% group, but it was probably not so significant. We carried out a meta-analysis on animal studies in this field because we don't have sufficient clinical data to do a clinical meta-analysis. So we summarized data from 3 studies, animal studies, who had been compressed with and used 21 or 100% oxygen, and it was equal outcome. Now, very recently at the PS meeting, Bud Durdin from Australia published these data from an animal model where they resuscitated with either air or 100% oxygen during chest compressions. And here, after reestablishment of circulation, you see that if you use 100% oxygen, you get this peak. But if you use air, you get this more physiological normalization. So should we wean gradually or rapid after we have established circulation? Well, according to this animal data, very new data, seems that the standard protocol suggested by NRP using 100% oxygen and wean slowly it leads to deep gray matter hyperoxia. I didn't show you those data, but also mitochondrial dysfunction. So a rapid wean from 100% oxygen to 21% after establishment of circulation maximizes blood oxygen content during chest compressions and reduces hyperoxia and mitochondrial dysfunction. And very recently in pediatric research, just a couple of weeks ago, Sankaran from Lakshmi Rushma's group, they showed in a newborn lamb model that weaning FO2 abruptly to 21% with adjustments then based on saturation prevents the surge in PO2 and CDO2 and minimizes oxidative stress compared to gradual weaning from 100% oxygen following circulation. So I think that there are now several data indicating that we should wean rapidly after chest compressions. So this is just to summarize oxygenation. Babies less in the delivery room, babies 35 weeks or more start with air, between 29 to 34 weeks, 21 to 30% oxygen. And for babies less than 28 weeks, we think we should start with 30% oxygen. Here's written at least 30% oxygen. We don't know the optimal FO2 for these babies. After reestablishment of circulation, wean to 21% rapidly, immediately, for term babies without lung disease. For babies with lung disease or preterm babies, maybe you should add some oxygen and titrate. And of course, you should titrate according to the preductal saturation, according to these targets. Okay, I think my time is running out, and I had just mentioned heat loss. Of course, it's important. And in 2015, this temperature line was added by ILCOR, maintain temperature during the whole procedure. And it's important to place the smallest babies into plastic to wrap them immediately after birth. Well, unfortunately, it doesn't seem to influence the outcome, at least not in this Cochrane review from 3 years ago, showing that major brain injury is not affected by this procedure, and death within hospital stay is not affected by this procedure. But still, we think that it is important to keep the baby warm, and I think you in India know that better than anyone else. And this recent study on kangaroo mother care shows that kangaroo mother care lowers mortality, the number needed to prevent one death, 27. So I would like to end up with emphasizing that. And here are the European guidelines from 2019. They recommend to delay cord clamping for at least 60 seconds. Oxygen should be controlled by using a blender. An initial FO2 of 30% is appropriate for babies less than 28 weeks, and 21 to 30% for those between 28 and 31 weeks, and adjustments should be guided by pulse oximetry. In breathing babies, stabilize with CPAP, 6 to 9 centimeter water via mask or nasal prongs. Sustained inflation should not be used. Intubation should be reserved for babies who have not responded to positive pressure ventilation via face mask. And in spite of the fact that plastic bags or occlusive wrapping under radiant warmers reduces mortality or other outcome, major outcome, it's recommended to put babies less than 28 weeks in plastic bags. We recently published a paper about delivery room handling, and for those who are interested, you find a reference. Yeah, it's in preparation, but it was published recently here, and I will not have time to go through all the points here, but you see that we have specified for low resource and high resource areas maybe we should have different practices. And here we have some of the variables we have discussed: cord clamping, the basic steps, heart rate assessment, meconium stain, amniotic fluid, indication to provide respiratory support and how to carry it out, and supplemental oxygen, cardiocirculatory support, temperature management, therapeutic hypothermia, discontinuation of resuscitation, and training strategies for healthcare providers. So for those who are interested, you can read this article. So I will thank you for your attention. I'm sorry I exceeded my time. And I'm happy to try to answer questions. Thank you so much.
Thank you so much, Professor Ola Saugstad. Sir, last year, 19 June, you inaugurated our webinar series with the elegant talk on oxygenation of newborn. And now you have taken us to another level by updating all the other aspects as well regarding the delivery room management. Friends, now we have another great legend with us during our special anniversary session to talk to us about the neonatal hypoglycemia, the recent updates and controversies. May I request my colleague Dr. Vishnu Mohan to kindly introduce the speaker.
Hello everyone. Richard A. Polin is the William T. Speck Professor of Pediatrics at Columbia University College of Physicians and Surgeons and is the immediate past director of the Division of Neonatology at Morgan Stanley Children's Hospital of New York Presbyterian. From July 1977 until Jan 1998, Dr. Polin was a faculty member in the Division of Neonatology at the Children's Hospital of Philadelphia and Professor of Pediatrics at the University of Pennsylvania. In 1998, Dr. Polin returned to Morgan Stanley Children's Hospital of New York as the Director of Neonatology. In the spring of 2006, Dr. Polin received the National Neonatal Education Award from the American Academy of Pediatrics section on perinatal pediatrics. In 2017, he was inducted into the Legends Hall of Fame. Dr. Polin has published over 200 original papers, 20 books including fetal and neonatal physiology, workbook in practical neonatology, pediatric secrets and fetal and neonatal secrets, and more than 200 abstracts. Dr. Polin is the chair of the NICHD Neonatal Research Network Executive Steering Committee, and he is the past chair of the Sub-Board of Neonatal Perinatal Medicine. Professor Polin in 2020 was awarded the prestigious Abgar Award, the highest award in the field of neonatology in the United States of America. It's our privilege to have you, sir, with us today. I invite you for your talk on neonatal hypoglycemia, updates and controversies.
Let me see if I see it now.
Do you want to go on like this, sir?
Yeah, it's fine.
You can tell me when to change. You can just say next, I will keep changing.
Okay, that's great. So why don't we get started? I'm sorry for any glitches. So my talk is about, obviously, neonatal hypoglycemia, and the subtitle is Beyond Quadragenous Septum Phobia. And for those of you who are scholars of Latin, you'll realize that quadragenous septum is the number 47, and phobia means fear, obviously. But for many years, the definition of hypoglycemia in the world's literature has been less than 47, and I will present you those data as my lecture goes on. If we could advance the next slide. So as I was preparing this talk, I decided to go to the internet and to Google and to see what is new about hypoglycemia. And there is some new information, but there's lots of websites like this that are from all kinds of legal groups in the United States. And if you look in the red on the slide, it says if the baby suffered brain damage or an injury as a result of these negligent acts, it is medical malpractice. So for many years, the greatest contributions have come from lawyers who have sued physicians for mismanagement of neonatal hypoglycemia. Next slide, please. So my objective is to bring some evidence or science to the recognition and management of hypoglycemia in newborns. Next slide, please. I have no financial disclosures. I'm not going to discuss any investigational drugs or off-label use. But importantly, I was one of the senior authors for the Committee of Fetus Newborn Guideline on neonatal hypoglycemia. That's the current guideline. And that is an area of controversy. And the controversy stemmed from an alternative guideline put out by the Pediatric Endocrine Society. Next slide, please. Here's my case. It's a preterm baby, AGA 36 weeks, at 1 hour of life. Before feeding, the bedside value is 24 milligrams percent. The infant is asymptomatic. What would you do? Remember, if those of you who work in millimoles, this is about 1 1/3 millimoles per liter. You can observe the baby and repeat the next screen at 4 hours. Allow the infant to breastfeed and repeat a value of 30 to 60 minutes, or treat the baby with intravenous dextrose. And I'd like all of you to make your decision, and I will go on. Next slide, please. So the correct answer is allow the infant to breastfeed and repeat a value in 30 to 60 minutes. All babies go through a physiologic or transitional hypoglycemia. And the recommendation by the Committee of Fetus and Newborn is to allow the infant to feed and to check a value 30 to 60 minutes later. Some people have said you ought to wait a little longer than 60 minutes to allow glucose values to normalize. If the baby cannot breastfeed, I think the best alternative is dextrose gel, but there's always the alternative of formula feeding. Next slide, please. Here's my outline. I'm going to start with, I think, some fundamental concepts about hypoglycemia, covering the hormonal responses to hypoglycemia, which are well described in adults. Then I'm going to switch and talk about what we call transient or biochemical hypoglycemia, trying to define hypoglycemia in neonates, and then trying to answer the question, are there morbidities associated with asymptomatic hypoglycemia? And finally, talk about recommendations and treatment. Next slide, please. So you may know this, but you cannot define significant hypoglycemia by a single number that can be applied to every baby. It varies with the disease state. Are they well appearing? Are they growth restricted, or are they depressed or with respiratory distress? What is their developmental maturity? Are they preterm or term? And what's the ongoing physiology? And that especially relates to the presence of alternative fuels, which can help spare the brain from hypoglycemia. Next slide, please. And the new concept is on neuronal fuel balance. Neuronal fuel balance is a combination of the blood glucose concentration, concurrent neonatal conditions, such as hypoxia and sepsis, and the availability of alternative fuels. The main alternative fuels are ketone bodies, lactate, and amino acids such as alanine and glutamine. How do you combine all of these things? You do a physical examination, because the physical examination takes into account alternative fuels, the blood glucose concentration, and the baby's clinical conditions. It's better than actually simply measuring a glucose concentration. Next slide, please. So the oldest definition for hypoglycemia is shown in the upper left hand part of the slide. And those numbers were defined by a very famous individual named Marvin Kornblath in the late 60s and early 1970s. Those values are in milligrams per DL. But he said in the first 48 hours of life, in a low birth weight infant, 20 is okay, 30 in a full-term baby, but by 48 to 72 hours, the value should be greater than 40 milligrams per DL. The Fetus and Newborn Committee, shown in the upper right part of the slide, selected a value of 45 milligrams per DL in the first day of life, and then it should be 60. The Pediatric Endocrine Society shows a value of 70, especially in babies who required any IV dextrose. And the number in the middle, 47, That still persists as the standard definition for hypoglycemia in newborns, and other practitioners choose to pick a value somewhere between 55 and 110. Next slide, please. So the newborn has an additional problem, is that the brain is very large compared to body weight. So if we look at this graph on the bottom, which looks at the brain to body weight ratio, it's highest in the newborn baby, and then goes down progressively with age. It's similar in men and women. And the brain is very important because it's the primary consumer of glucose from the bloodstream and has limited supply of reserve fuel. The brain consumes about 20% of the glucose in the blood. Next slide, please. Here's some additional concepts which are important. There are no evidence-based studies that define glucose levels leading to irreversible brain damage. There's no evidence that treating asymptomatic hypoglycemia improves neurological outcomes, no matter how low the value. And in fact, the third area is still a controversy. If asymptomatic hypoglycemia goes on for a long period of time, does that cause brain damage? Well, the data using interstitial glucose monitoring suggests that even persistent asymptomatic hypoglycemia does not cause brain injury. Next slide, please. The signs of hypoglycemia are defined as twofold. We've all experienced neurogenic hypoglycemia. This is adrenergic and cholinergic signs in response to a fall in blood glucose. So you can have palpitations, tremors, anxiety, sweating, or feeling of hunger. In the adults, that occurs at a value of 50 to 60 milligrams per DL. That's about 3 millimolar per liter. And then there's neuroglycopenia in the adult, causes confusion or coma or seizures in newborn babies. It occurs at a value of less than 50. However, in neonates, we don't know the value that causes neuroglycopenia. Next slide, please. And the next slide, please. So in the adult, glucose levels are regulated in a fairly narrow range by endocrine or hormonal changes. Next slide, please. And this slide looks at the hormonal responses to a fall in blood glucose concentration, again, in the adult, but we can presume these similar findings occur in newborn babies. So the first response on the upper left part of the slide is decreased insulin. Obviously, decreased insulin decreases glucose utilization. It helps return the baby to normal glycemia. And then there's a series of other hormonal responses. Glucose and adrenaline or epinephrine increase glycogenolysis, involving the activation of adenyl cyclase. Gluconeogenesis is supported by cortisol, and the two other hormones, growth hormone TSH, affect all three of those responses. Glucogenesis involves glucose precursors, and the precursors are glycerol, lactate again, and amino acids. The glycerol comes from lipolysis. Lipolysis releases glycerol and increases free fatty acids. It also releases ketone bodies, and it's important to remember that ketone bodies are one of the most important alternative fuels. So all three of these processes are important to spare the brain and to restore glucose values to normal. Next slide, please. And this are data from adults looking at the hormonal changes at various levels of plasma glucose values in milligrams per DL. So as the values fall below 85, insulin is shut off. 65 to 70, you have glucagon and epinephrine, which increase glycogenolysis. And that's when neurogenic signs of hypoglycemia appear. And below 50, you have growth hormone and cortisol come into effect. And those are when the symptoms of neuroglycopenia or lethargy or coma or seizures occur. Next slide, please. This is a cartoon looking at transient or biochemical hypoglycemia. And in all newborn babies following birth, blood glucose or plasma glucose values fall, at which time insulin is turned off and glucagon levels increase to normalize glucose values by about 4 hours of life. Next slide, please. And these are the actual values from a group of about 350 term babies. And if you look at the blue dotted line, those are mean. The other colors represent 2 standard deviations from the mean. But levels fall from about approximating levels in the adult at the time of birth. The minimal glucose, if you look at mean values, is in the range of 50 to 60, and then it rebounds. But you can see there's a wide standard deviation as represented by the orange and red colors. And again, next slide, please. The Pediatric Endocrine Society likes to use mean values to define hypoglycemia. The Committee of Fetus and Newborn in the United States likes to use the ranges, and we call those operational thresholds, which provide a margin of safety for treating hypoglycemia. Next slide, please. And this slide looks at the time of the occurrence of the hypoglycemia and the level at which it falls. So full-term babies are the solid black line. Preterm, late preterm babies are shown by the dotted blue line. And you can see they reach their nadir somewhere between 80 and 100 minutes of life. And the value of their nadir on average is about 60. But preterms, which are defined here as 28 to 34 weeks, and extremely low gestation age newborns, less than 28 weeks, as shown by the dotted red and green line, fall to a value much earlier at 60 minutes of life, and they fall to a significantly lower value. Next slide, please. Well, these are, again, our data from healthy term babies and trying to define what is normal glycemia. So you can see that all the values, we're looking at mean values now, from 1 to 2 hours up to 72 hours, we would consider, I'm sure you would consider normal. But if you look at the 5th percentile, 2 standard deviations from the mean, some of the values, especially in the first couple hours of life, where you have transitional hypoglycemia, can be quite low, and then they rebound to a value of about 40, which is about around 2 millimolar per liter. Next slide, please. And this is a study on breastfed babies, looking at mean and median values at 3, 6, 24, and 72 hours. The mean and median values are not much different from what I just showed you, but the range in breastfed babies is lower. So in general, breastfed babies have a lower plasma or blood glucose concentration. You can see the numbers in red there. But we know from data on breastfed babies that ketone bodies are increased in response to breastfeeding, and ketone bodies represent one of the most important alternative fuels. Next slide, please. So after the first transitional hypoglycemia, you can see in this slide, again from healthy term babies, that mean values are around 3 millimoles per liter, or about 50 to 60 milligrams per DL. And they remain fairly stable. Next slide, please. But on day 4 to 5, and these are recent data, looking not only at the blood glucose concentration by sampling plasma, but looking at what's called interstitial glucose monitoring, which is an experimental tool in which they have continuous glucose monitoring. And you can see here that on days 4 or 5, 96 to 120 hours of life, all glucose concentrations rise spontaneously. It's interesting that a plasma glucose level less than 47, that old definition, turns out to be about the 10th percentile in the first 48 hours. But lots of babies, lots of healthy term babies, almost 40%, had at least one episode below that threshold. Next slide, please. Transient hypoglycemia is a complex problem, and unfortunately, it can be associated with hyperinsulinemia. And people have looked for high insulin levels in the highest risk populations. If you look at the second bullet point, that's in growth restricted babies, late preterm babies, IDMs, infant diabetic mothers, and large gestational age babies. And remember that hyperinsulinemia suppresses a lot of the alternative fuels like lactate, beta hydroxy, butyrate and acetoacetate, and glycerol. So hyperinsulinemia is a problem because those alternative fuels help spare the brain. If they're depressed, there's a greater risk of neuroglycopenia or perhaps brain injury. Next slide, please. These next two slides look at the glucose values at which insulin is suppressed. The figure on the left represents in children, and you can see at a concentration of 4 to 5 millimoles per liter, glucose concentrations are turned off. In term infants, it goes down much lower. So in a term baby, glucose is suppressed at a glucose concentration of 3 to 4 millimoles per liter, or a glucose concentration of in milligrams per DL, 55 to 65. And the next slide looks at our preterm population. Next slide, please. And the preterm population, the insulin levels shown on the y-axis are difficult to suppress even at very low glucose concentrations. These are all preterm babies, but none of them are infants of diabetic mothers. Next slide, please. So here's data comparing glucose levels, insulin levels, and ketone body levels in a group of preterm AGA babies at 32 weeks, term AGA babies at 39 weeks. And we're looking at cord blood values, and then children 1 month to 10 years of life. And you can see here they all had normal glucose concentrations, shown on the third line down, but insulin levels were significantly higher in the preterm AGA babies, and ketone bodies, because insulin suppresses ketone bodies, were significantly lower. Insulin levels were slightly higher in term babies, and ketone bodies were slightly lower in term baby as compared to children. Next slide, please. And we talked about alternative fuels, and this is a recent paper from, I believe it's McKinley et al., looking at alternative fuels in the first 5 days of life in healthy term babies. And the upper graph, if you look, is lactate, the lower graph is beta-hydroxybutyrate. So just to quickly summarize, lactate levels are higher in the first 12 hours of life and then dip down, where beta-hydroxybutyrate levels are low in the first 24 to 48 hours of life and then increase. Next slide, please. Well, the authors went on and tried to see what's the relationship of those alternative fuels to hypoglycemia. And they chose a value that I don't consider hypoglycemia, which is greater than or less than 60 or less than 67. And they noted that babies with glucose values less than 67 had lower lactate values. However, babies with interstitial glucose monitorings that were low finally increased their beta-hydroxybutyrate levels, but only if the hypoglycemia lasted more than 12 hours. So the alternative fuels were not available in the first 12 hours of life, but with persistent hypoglycemia beyond that time, beta-hydroxybutyrate appears to be an effective alternative fuel. Next slide, please. So how do we define hypoglycemia? You can do it by epidemiologic studies, clinically based on manifestations, but most manifestations are very non-specific. Physiologically, which has been done in the adult, looking for hormonal responses, or based on neurodevelopmental outcomes. Next slide, please. There have been 2 reports I've already mentioned. One of them, a report from the Committee of Fetus and Newborn, initially put out in the early part of this decade, 2011, but reaffirmed in about 2018. And next slide, please. Our recommendation was to use operational thresholds. An operational threshold is much wider than that chosen for the Pediatric Endocrine Society, but it provides a guideline when you should intervene for hypoglycemia. It provides a margin of safety before babies become symptomatic. Next slide, please. The other report was from the Pediatric Endocrine Society, in which they thought that a minimum concentration in the first 48 hours of life ought to be 50, and then 60 after 48 hours. But in any baby who required additional glucose, you ought to have a minimum glucose of 70 before discharge. Next slide, please. Well, the people who wrote the report from the Pediatric Endocrine Society are actually friends of mine from the Children's Hospital of Philadelphia, but they were quick to criticize our report from the Committee of Fetus and Newborn. And this is what they said: you should be looking at metabolic and hormonal data to establish critical glucose levels. You're missing cases of persistent hypoglycemia by your guideline, and you're not treating infants effectively and placing them at risk for brain injury. Next slide, please. So the starting point for statistical definition has been criticized, and the editorial is written by William Hay, saying that a statistical norm, choosing a value, does not define a biologic norm. We don't know when irreversible brain damage occurs in babies, nor does it address the associated conditions which might affect a important or critical glucose value. Next slide, please. So the first individual, I've already mentioned this, is Marvin Kornblath in the late 1950s, chose these ranges, which I've already said, less than 30 in a full-term baby, less than 20, and that's about a millimole and a half, or a little more than a millimole in low birth weight babies in the first 2 days, and then beyond that, a level of 40. Symptoms that are present at at 1.4 millimoles per liter, or a value of 25, resolved when the baby's concentration reached 40 or 2.2 millimoles per liter. And Dr. Kornblath concluded that if glucose concentration is safe, if clinical signs associated with hypoglycemia are not observed or disappear with treatment. Next slide, please. The problem with that, and we followed those guidelines for about, at least for 10 years. Next slide, please. So what's wrong with that report? There's a lack of follow-up data. Symptoms they said were due to hypoglycemia were very non-specific, or were probably due to other conditions in babies. And he did not evaluate other alternative energy substrates, which might spare the brain, including ketogenesis with milk feedings. Next slide, please. And then we go to the study by Alan Lucas, a very famous study of 660 preterm babies. Mean gestational age was about 30 weeks, mean weight about 1,300 grams. And this is the study where he defined 47 as being the key definition of hypoglycemia. And in this study, they did daily measurements of glucose. It was intermittent monitoring up to about the second or third or week of life. And then it did weekly sampling of babies until they reached a weight of 2,000 grams for the 9th week. And ultimately, what makes this a great study, they did developmental testing. Next slide, please. So they rarely saw severe hypoglycemia, less than 0.6 millimoles per liter, or a milligrams per DL would be a value of around 10. Values less than 47 were very common. Overall, 16% of the whole population between 3 and 30 days. And in babies less than 1,000 grams, it occurred in almost 40% of the babies between 3 and 30 days. Next slide, please. And this is their follow-up data. They looked at the adjusted odds ratio for neurodevelopmental impairment in the number of days they had a value less than 2.6 or 47. So if it was 0, obviously the relative risk was 1, no increase. If it occurred on 3 to 4 days, the relative risk increased to 2.2. More than 5 days, the numbers increased to 3.5. And those data were actually very frightening to those of us who were in practice. Next slide, please. However, when he looked at 7 to 8 years, none of these differences had statistical significance. So this was only in an 18-month follow-up, which you know can be problematic. Next slide, please. If you choose a value of 47 or 2.6 millimoles per liter, you're going to be treating a lot of babies. Next slide, please. And this is a figure which shows how frequently values of less than 47 or 2.6 millimoles per liter are seen. In large babies, in the green of the slide, almost 40% of the time. IDMs, 49% of the time. In purple, growth-restricted babies, 56% of the time. And the preterm population at all, about 60% of the time. Obviously, you can't treat all those populations that have a value less than 47. Next slide, please. Next slide, please. And this is a follow-up stuff from Win Tin in Middlesbrough, England, who tried to say, well, how significant is that value of 47? So they looked at index cases that had at least 3 days less than 47, or controls that always had values greater than 47 or 2.6 millimoles per liter. This was a prospective observational study of babies less than 32 weeks. Next slide, please. And when you go back, and this is the outcomes they looked at, everything from IQ, personal and social behavior, hearing, speech, performance, eye-hand coordination, and locomotion. And there was no difference between control infants who never had values less than 47 or index cases that had at least 3 days of values less than 47. Next slide, please. And the study that is contrary, and I think it's an important study, came from Jeff Kaiser down in Arkansas. He looked at this issue of transient neonatal hypoglycemia at 3 different levels, which are shown on the slide here: less than 35, less than 45, less than 40, or less than 45, in babies of a wide gestational age range, 23 to 42 weeks. Not surprisingly, the hypoglycemic babies were smaller and less mature. Transient hypoglycemia occurred in 6.4% of babies with values less than 35, 10% of babies less than 40, and almost 20% of babies had values less than 45. Next slide, please. And they showed, and on this side, we're looking at a table with the 3 important ranges: less than 35, less than 40, and less than 45. And they're looking at proficiency and literacy in mathematics. And almost everything in this table is abnormal. You can see here the odds ratio for reduced literacy and the odds ratio for reduced mathematic performance was less than 35, less than 40, and less than 45. Only in mathematics was this value on the bottom right, decreased proficiency in mathematics with values less than 45, not significant. Next slide, please. But that study has been criticized, and the editorial made the following points. They didn't describe management or how many babies were breastfed. The study only looked at transient hypoglycemia, so therefore they can't rule out recurrent hypoglycemia. And basically, causation can't be reviewed. The babies experiencing hypoglycemia may have abnormal intrauterine development and may have been destined for poor outcomes. Next slide, please. So an important question. A lot of people have done intermittent sampling to define hypoglycemia. It's less than ideal. So in the studies I'm going to show you, next slide, the authors used a technique of not only intermittent sampling, but also they used interstitial glucose monitoring, where the babies had continuous monitoring. And in this study, the values were obtained by intermittent sampling were available to the practitioners, and they treated the hypoglycemia with supplemental feedings, with or without IV dextrose or dextrose gel. But the values of interstitial glucose monitoring were not available to the practitioners. Next slide, please. So 53% of babies in this study had, when they looked at, had values less than 47. 25% of the babies had hypoglycemia, a value less than 47, only detectable by interstitial glucose monitoring. And a quarter of those treated for hypoglycemia, based on the intermittent sampling, had at least 5 hours of low interstitial glucose values in the first week of life. And that's why I said early on that even persistent asymptomatic hypoglycemia is probably not clinically significant. Next slide, please. So they looked at neurodevelopmental impairment, and in fact, they could not identify any relationship with values less than 47, the number of unrecognized episodes, the number of severe episodes, or the duration of hypoglycemia. But they noticed something very interesting, and I think it's important clinically, that cognitive delay was associated with higher glucose concentrations and less glucose stability. Next slide, please. And on this figure, I want you to look at the figure on the left, which is children treated with dextrose, and the red line indicates children with neurosensory impairment. So the children with neurosensory impairment treated with dextrose had significantly higher glucose values, where the hypoglycemia didn't appear to make a difference. So our treatment for hypoglycemia may be the significant variable. Next slide, please. And Dr. McKinley looked at outcomes at 4.5 years of life. This was a prospective study, again, of babies greater than 32 weeks gestation. of about 470 babies with neonatal hypoglycemia, less than 47. They define a severe episode as less than 36, or recurrent episodes, which was greater than 3, which occurred in about almost 20% of babies. Again, hypoglycemia was not associated with neurosensory impairment. However, it was associated with dose-dependent abnormalities in executive function and in visual motor integration. Children who developed those impairments between 2.5 and 4 years of age had the steeper rise in interstitial glucose concentrations after hypoglycemia, making the point that it's our treatment for hypoglycemia, use of intravenous glucose, the rapid correction, which may be the significant variable. Next slide, please. This is a study which is a follow-up study looking at glycemic stability. Is by Bukharovich, doesn't show on the slide, and neurodevelopmental outcome. And what they showed is that the rate of change in glucose concentration after an episode of hypoglycemia was related to adverse neurodevelopmental outcomes. Next slide, please. And this is a meta-analysis. The trouble with this meta-analysis is most of the data I've already showed you. It's 4,000 babies greater than 32 weeks gestation. Next slide, please. And if you look at the meta-analysis, in early childhood, there was no difference in neurodevelopmental impairment. Here's the odds ratio. Here are the confidence intervals. But they felt the data was low or very low quality, which means it's suspicion. So it's very suspicious for being inaccurate. Next slide, please. And here's the actual meta-analysis. And there's no difference in neurodevelopmental impairment. And they looked at visual motor impairment and executive function, showing a relationship with babies who had hypoglycemia. However, this is all based on the McKinley data. And again, the babies with these impairments showed a steeper rise in glucose concentration following treatment. Next slide, please. And finally, I'm going to end with the hypoxia study, a fairly recent study, 2020, published in New England Journal of Medicine. This is babies who were late preterm or term babies falling into the 4 high-risk groups of IDMs, infants and diabetic mothers, growth-restricted babies, large gestational age babies, and late preterm babies. And they used 2 thresholds for intervention, greater than 36, where they intervene, or greater than 47. Next slide, please. Primary outcome was psychomotor development at 18 months. It was a non-inferiority trial trying to show that intervening at a lower threshold produced a lower psychomotor development. Next slide, please. And here's the results. Absolutely no difference at 36 or 47. Here are the mean cognitive scores and mean motor scores. Next slide, please. This does not mean that 36 is safe for all babies. Treatment at a threshold of 47 may prevent recurrent episodes of hypoglycemia or severe episodes. The number of infants and diabetic mothers in the study was less than optimal. Follow-up is only performed at 18 months. Again, that is suboptimal. And 16% of the babies were lost to follow-up, which is higher than desired. Next slide, please. And finally, I'm going to end talking about universal screening and also about treatment for hypoglycemia. Next slide, please. These are the high-risk groups we should consider screening. Any baby with signs of hypoglycemia, the 4 high-risk groups we've already talked about, IDMs, LGA babies, large gestational age, premature or post-mature babies, growth-restricted babies. Any baby that had perinatal distress or stress should be screened. Obviously, if there's a family history of hypoglycemia or certain syndromes like the Beckwith-Wiedemann syndrome, we know is associated with hyperinsulinemia and hypoglycemia. Next slide, please. Next slide, please. Who should be investigated for hypoglycemia? Any baby with severe hypoglycemia, any infant with symptomatic hypoglycemia, a prolonged episode of hypoglycemia, or unable to maintain a value of at least 60, a value of a family history, and obviously a congenital syndrome. Next slide, please. The principles of treatment: identify the babies, restore the blood glucose concentration to a normal range. What we don't know if that improves neurodevelopmental outcomes. Next slide, please. So the AAP developed its algorithm actually before the Pediatric Endocrine Society, and this is what we concluded. Almost all infants with proven symptomatic hypoglycemia in the first hours of life have values less than 20 to 25 milligrams per DL, or about 1 to 1 1/3 millimoles per liter. There's little or no evidence that asymptomatic hypoglycemia is harmful to babies, and this allows us to establish operational thresholds or a safe margin of safety. Next slide, please. There's our 4 high-risk groups. Next slide, please. And these are our recommendations. This is available on the Academy of Pediatrics website, or you can just Google the Committee of Fetus and Newborn Guidelines. So if a baby is symptomatic at any time, you consider the baby symptomatic and values less than 40, that's a baby who needs IV glucose. And I generally try to treat now with an ml per kilogram of 10% dextrose and then a continuous infusion. If between birth and 4 hours of life, you give an initial feed and check the glucose within 30 minutes after the first feed. If the initial screen is less than 25, feed again and check in an hour. If it's less than 25, our recommendations was for IV glucose. If it's between 25 and 40, refeed. I prefer not to use IV glucose for the data I just presented. And then between 4 and 24 hours, the baby's on continuous feedings. Screen prior to each feed in the high-risk groups. If the value is less than 35, feed again and check in an hour. If it remains less than 35, consider IV glucose. Between 35 and 45, refeed and use IV glucose as necessary. Next slide, please. Breastfeeding, we have already talked about. The values tend to be lower, but they have higher ketone bodies. The average intake of colostrum in the first day of life is about 7 mLs, or about 15 to 20 mLs per kilogram per day of breast milk. Majority of breastfed babies have values less than 30, but around 12 to 14% will have values less than 47. Next slide, please. Dextrose gel is being used increasingly around the world, and we use it in our hospital now to treat hypoglycemia. A famous study is the sugar baby study, at-risk babies who are late preterm with documented hypoglycemia randomized to 40% dextrose gel at that concentration, or plus feedings, or placebo plus feedings. The primary outcome was treatment failure, or a value less than 47. And dextrose gel did work, reduced the risk of treatment failure from 24% to 14%, and reduced the rate of NICU admissions. And then in a subsequent study, Harry shows similar increase in glucose concentrations with formula feeding and dextrose gel, but greater than with breast milk. However, breast milk decreased the risk of recurrent hypoglycemia. Next slide, please. And these are my conclusions. First of all, no guideline is perfect, not even the fetus and newborn guideline. There's little or no consensus on the significance of transient and asymptomatic hypoglycemia, but I consider it to be benign. Most data that indicate adverse outcomes do not occur with such conditions. Next slide, please. Infants with transient hypoglycemia should not go home unless there's solid evidence through several feed fast cycles that they can maintain a glucose greater than 60. For infants requiring treatment, IV glucose, you would select a value of at least 70, which is around 4 millimoles per liter. Next slide, please. And persistent or recurrent hypoglycemia, that does require an endocrine evaluation and consultation with one of the endocrinologists in your hospital. Thank you very much. Thank you, Manoj. It's Dr. Manoj. It's been a great pleasure to participate in this symposium.
So the honor is totally ours. As I said, it is such a honor to have you and then hear about the recent concepts in neonatal hypoglycemia. Now, friends, we will have a discussion sessions slightly prolonged. Apologies for that, but we'll have discussion. To moderate the discussions, I request my colleagues, Dr. Ravindra Verma and Dr. Murilraj, to take over and start with the questions. I request all of you to kindly post your questions only in the Q&A box, not in the chat box. so as to enable us to sort out the questions and ask, because there are too many questions now and we are running short of time. So I would request the moderators to put the questions together and then ask. Please go ahead.
Thank you, Professor Saugstad and Dr.
May I request Professor Ola also to kindly...
Professor Ola, please come on. Can you enable the video, please? Professor Saugstad, please.
Until Professor Saugstad joins, carry on with the questions. Please.
I think so. I think we will start with, since Professor Saugstad is not there, we'll start with Professor Polin. Anyway, thank you very much, Professor Saugstad and Professor Polin, for your enlightening talks on two very practical talks. As far as neonatologists are concerned. The first question to Professor Polin is probably an interesting one. You have put up in the slide, quadrigentiphobia. What does that mean?
So that's the Latin for 47. And I chose that because for many years, even now, 47 is thought to be the definition of hypoglycemia.
Okay, somewhat similar to the vigintiphobia, which you used to have with bilirubin itself.
That is correct, and that's why we chose that.
Yeah, right. The next question is, Volpe's textbook says that a sugar less than 47 in symptomatic neonates leads to long-term deficits in neurodevelopmental outcome. Your opinion, please.
So symptomatic hypoglycemia is much more of a concern. Clearly, a baby who's lethargic or in coma or has seizures requires immediate treatment. The problem is that babies have lots of symptoms, and it's hard to sometimes distinguishing babies whose symptoms are due to hypoglycemia versus babies that are due to other conditions. But if you think it's less than 47 or 2.6 millimoles per liter, and the baby's symptomatic, you ought to treat it.
All right, thank you, sir. Now, there are some people who are very worried. So, which number? Do you have any number? It must be about asymptomatic hypoglycemia. Which number you should be worried about?
Yeah, I wish I knew. I could answer that question. So for transient hypoglycemia, I'm not so concerned as long as the value in the first day of life goes up above 45. Beyond the first day of life, I choose 50 milligrams per DL, about 3 millimoles per liter. Prior to discharge, I like to see values greater than 60, unless they require, which is about 3.5 millimolar, unless they require IV glucose, in which I do follow the endocrine recommendations for maintaining a value of 70 or about 4 millimoles per liter.
Right, thank you, sir. I think the person who has asked should be clear by now. Now, is there a need for admission to the nursery for infant of a diabetic mother with IV fluids and breast oral feeds, or can you manage them in the wards with oral feeds? I think it must be asymptomatic. That is what I feel.
So it depends on the staffing you have in your routine wards. Any baby with documented hypoglycemia who's born, and we call our transitional nursery, is admitted to the NICU to make sure that glucose values can be maintained in a normal range. But if your hospital has a good way of following those babies, has adequate nursing staffing, and the baby's active, I think you can manage those babies in a different setting.
Probably the worry was probably if the baby is hyperinsulinemic, the alternative fuels also may be low. That may be the worry. The question.
That is correct.
Probably,
in fact, they are low.
Yeah. The next question: what is the difference? What is the difference between hyperinsulinism and hyperinsulinemia?
No, I'm not sure what the difference is. Babies, I've talked about all 4 categories of at-risk babies can have hyperinsulinemia. Hyperinsulinism, I view it maybe as a different disease like Beckwith-Wiedemann syndrome that has persistent hyperinsulinemia. But on high-risk babies, it's probably not persistent, but it's associated with hypoglycemia. So I use the term hyperinsulinemia.
All right, thank you, sir. Dr. Cruz has asked, is there any evidence for association of hypoglycemia with gray or white matter injury?
So symptomatic hypoglycemia has been associated with neurological injury. These are babies with seizures or lethargy or coma. We used to think that the injury was localized with hypoglycemia to the posterior occipital region, but we know now that with persistent symptomatic hypoglycemia, the damage can be more diffuse. I mean, we know that from MRI studies.
All right. Thank you, sir. Now, somebody has asked how to calculate the glucose infusion rate. Is it from the feeds as well as IV fluids, or from the IV fluids alone?
From the IV fluids, you look at the glucose concentration in the IV fluids. 10% is 100 milligrams per DL per deciliter, and you look at your IV fluid rate, and you can look at the delivery of how much glucose you're giving. And to maintain glucose, you need somewhere between 5 to 6 milligrams per DL per kilo per minute.
What about the oral feed? Do you calculate?
No, we don't. We as a transition to getting babies off IV glucose, we always start enteral feedings. If they can't nipple, we feed them via tube, and then watch glucose values, and then wean the IV glucose. I made a mistake. It's 5 to 6 milligrams per kilogram per minute.
Doctor, I think now I'll hand over to Dr. Murali Raj. Can you ask the questions, please?
Yeah, sure. Thank you, Dr. Polin, for your wonderful and enlightening talk. Since we are running short of time, I will be going fast through the questions. So that is a reliable, what we have to measure, that is while measuring blood glucose, whether it is plasma or all blood glucose?
You can measure either.
Okay.
Plasma glucose is probably a little higher than whole blood, but you can measure either. Okay. And the same numbers apply.
Okay. Thank you, doctor. And the same person wants to know why a sudden increase in the glucose following a hypoglycemic treatment causes neurological problems.
I wish I knew. I don't know, but it may be free radical production. That's a potential theory.
Probably the osmolality changes also maybe. How frequently these risk babies should be screened? Is there any evidence based? We have got 2-3 questions about that. That is the frequency of monitoring these high risk babies for blood glucose.
Well, we monitor them pre-feed for about 36 to 48 hours. And then if everything is stable, we stop. Healthy, I should have said, but healthy term babies do not require any screening at all.
Okay. Other question is, will you advocate to avoid using bolus dextrose in asymptomatic hypoglycemia?
I would not do that. I would try to treat asymptomatic hypoglycemia with dextrose gel or increased feedings, and try to stay away from bolus, because bolus has 2 problems. It makes babies hyperglycemic, and it may cause brain issues or damage, and it also increases insulin output. So it's the Samoji effect, that a bolus of glucose increases insulin, which causes more hypoglycemia.
Yes, true. We have another question about dextrose gel. It is not available in India. Some papers suggest it can be prepared easily. So I don't know how it is prepared easily. So what is your opinion about
I've
the
not made it
indigenous
myself, but I bet your diabetic population has dextrose gel. I'm guessing for children and adults with diabetes, they have dextrose gel available, and that can be adapted to the neonate. I've not made it myself.
Okay, thank you, Professor. And we have another question from Dr. K.K. Divagar, one of the senior neonatologists from Kerala. How was the 40% for glucose gel arrived at? And honey has approximately 38% of fructose and 31% of glucose and 7% of maltose. Cannot this be a good alternative to 40% dextrose gel?
It may be. I just don't know of any studies. It's a great question to substantiate that.
Okay. So another question, important question is, at what GAR would you recommend hydrocortisone?
So it's a great question. If you can't maintain glucose values in a normal range by intermittent feeding and IV glucose, we would use hydrocortisone. That's one of the oldest. It promotes gluconeogenesis, as we already talked about. It is effective in lots of babies. In the most severe babies, we've used diazoxide, but that's in a very small percentage of babies.
Okay. So we have got 2-3 questions about the monitoring of sugars of infant of diabetic mothers. On how frequent to monitor, that you already answered, and how long to monitor in an infant of diabetic mother.
Yeah, I follow sort of for all the high risk groups. I try to monitor them through 48 hours or 36 to 48 hours through several feeding cycles.
Okay. Now I'll request Dr. Ravindra Varma to continue with the rest of the questions.
Right. One question is how to identify the IUGR babies which are really at risk for hypoglycemia, so we can prevent it.
So we define IGR based on the baby's weight. And obviously, some babies will have weights above the less than 10th percentile who are still growth restricted. But we define it in our nursery as any baby with a weight less than the 10th percentile.
Right. Okay. In case of moderate hypoglycemia, is it safe to add oral dextrose to baby's feeds?
I've not done that. You can increase the caloric concentration of the feeds. I've not added. I worry about dextrose increasing the osmolality quite high. So we increase the volume of feeds. You could add fortifier to breast milk if necessary, or you can increase the IV glucose rate. But I've not added. I guess 5% dextrose is pretty safe, but I've not added other concentrations of dextrose.
Another question is on critical sample. When exactly would you recommend to take a critical sample? That is the various investigations. There are a couple of questions on that as well. When to investigate and what all investigations to be done.
So critical samples. I hope I made the point that looking for transitional or biochemical hypoglycemia is not of value. You really want to look at a sample after a feeding in our high-risk populations. So it's generally 60 minutes after a feeding, check glucose values. And if a baby can't maintain normal glycemia, a value of at least 70, we get our pediatric endocrinologist involved, and they go through an extensive workup looking for alternative fuels, looking for cortisol values, growth hormone levels, looking for other causes of hypoglycemia in babies. So the critical value, if they can't maintain a 70, we're always getting our pediatric endocrinologist involved. Or we think we have a genetic syndrome. If I have a baby with Beckwith-Wiedemann syndrome, we always get the endocrinologist involved.
Right. Thank you, sir. Now, somebody has asked, what is the GIR, glucose infusion rate of breast milk?
So I don't know GIRs in breast milk. Or formula. Only for IV glucose.
Right. Right. I think, have we covered all the questions by now?
One more question is there any role of higher calorie formula on the treatment of hypoglycemia?
Yes. So going to 22 calorie per ounce or 24 calorie per ounce formula, absolutely.
Okay.
Or if it's breast milk, you can try to fortify it.
Okay.
Another question is, baby with seizures, do you recommend dextrose in all cases or only those with documented hypoglycemia?
We do a heel stick almost immediately. If the glucose value is normal, we don't give IV glucose. We treat the seizures, look for all the other causes, potential causes of seizures.
Right, I think we have.
Few questions are also there. And
can you go through that then?
Prof. in the meantime, can I ask you a question?
Sure.
You had very elegantly told about the interstitial glucose monitoring and the continuous glucose monitoring, interstitial glucose. So what is the role, like in adult medicine, it's coming up in a big way. What is the role you see in the future regarding the role of CGM? Because we need continuous monitoring in babies if some of the issues are to be sorted out.
It's a great question, Dr. Manoj. It's a new and exciting technology. We need more data to show that is useful for preventing injury in babies, but it's an easy technology. It appears to work very well and correlates very well with blood glucose values. So I think there's a great future. We need more data.
Thank you. Thank you.
Dr. Divagar has asked one more question. Do glucose strips available in the US match with the blood glucose values which you measure?
Pretty well. Sometimes if they're very low, they don't correlate very well. But they do correlate fairly well with the blood or plasma glucose value.
Right. Okay. There is another question regarding the diazoxide. When you start diazoxide, do you have to give a diuretic to prevent fluid retention?
Yeah, we sometimes do. We use it so infrequently, and it's a baby with a beta cell hyperplasia or nasidioblastosis or Beckwith-Wiedemann syndrome. So it's so unusual for us to treat with diazoxide.
There is another long question. Over the years, endocrinologists advise for not to miss opportunity for hypoglycemia screening for endocrine and metabolic causes and pick on the missed opportunity during neonatal period. Keeping low thresholds to screen for hypoglycemia, is there a reason to have a good pick-up rate for other diagnoses?
I think if you can maintain a glucose value of at least 70 in a baby who's been treated for hypoglycemia, you're pretty safe in discharging that baby and said there's not going to be recurrent or severe hypoglycemia.
Right. And what is the highest dextrose concentration that can be used for persistent hypoglycemia despite other adjunct treatment?
It depends on whether you have a central line or a peripheral IV line. In peripheral IV, we don't go above 12.5% glucose peripherally. Central line, you can go up to 20% if it's in a good location.
Great, thank you, sir. I think.
So one more interrogation is there that do you recommend cord blood sugar in an infant or diabetic mother?
Getting a cord blood sugar? No.
In infant or diabetic mother, no. Okay. And the same person wants to know how long does a transient hyperinsulinemia persist in SGA baby? SGA baby and hyperinsulinemia.
Yeah, I don't know how long it persists, but it becomes clinically insignificant after the first couple of days of life. So it may persist longer, but it's not a clinical problem.
Yes, probably this will have this substrate deficiency rather than hyperinsulinemia. And the same person has a doubt that any detectable insulin in a baby with hypoglycemia, is it abnormal? That is hypoglycemia baby, there is we detect some insulin, so it is abnormal. What is your comment, sir?
I'm sorry, can you repeat the question for me, please?
Any detectable insulin in a baby with hypoglycemia is abnormal. Your comments on that?
You're saying if the insulin level is abnormal?
No, if the baby is having hypoglycemia, and if there is a detectable level of insulin in such baby, is it abnormal?
It probably is. I mean, the endocrinologist would screen babies with glucose levels, with insulin levels, and ketone bodies as an initial screen. Again, ketone bodies should be lower if there's hyperinsulinemia.
And do you recommend doing MRI in symptomatic hypoglycemia? And if yes, at what time?
Do I recommend what? I'm sorry.
If there is any, do you do an MRI in babies with symptomatic hypoglycemia? And if yes, at what age do you do it?
So I don't know the word MRI. What is it?
Magnetic resonance imaging.
MRI.
Oh, good. MRI. Sorry.
Yeah. Sorry.
Do I do an MRI? If a baby has had symptomatic needing treatment, I think an MRI is warranted.
And at what age will you do an MRI?
When they leave the hospital in early infancy.
Okay. Right.
I have to run to an. I have to.
Yeah. Thank you.
Yeah.
Thank you, Professor Polin, for that wonderful interactive session. Thank you very much. Have a good day.
It's been my pleasure.
Thank you so much, Professor Polin. Unfortunately, Professor Ola is unable to connect due to some technical glitches. Professor Polin, it was such a honor once again, from the bottom of all our hearts. We thank you so much. This is a special occasion for us, and you made it more special by your presence. And we love to hear your talk today. We love to hear you more. and then we would love to have you when we host the physical conference, hopefully towards the end of this year or next year when the pandemic is over. Thank you so much.
And I would love
Thank you.
to come back
Thank
to
you, sir.
India.
That would be a true honor, sir. Thank you so much.
Thank you, sir.
Now, before we close, I would request the President of NNF Kerala, Dr. Ravi, to propose a vote of thanks. Thank you, everybody.
So, good evening, everybody. It has been a truly enriching experience listening to two great authorities in neonatology at the global level. Professor Ola Didrik Saugstad from Norway and Professor Richard Polin from USA were truly amazing. Their rich experience would pave way to strengthen our knowledge in the practice of neonatology in India. I'm sure we will be able to meet them shortly during the conference proposed in February 2022 at Trichur. Thank you once again, sirs, for being with us during the last 2 hours and making it a grand success. Thank you one and all for the great participation and the wonderful interaction. Thank you very much and a good day.
Thank you, sir. And thank you once again, Professor Polin. Now, before we wind up, just a small announcement we forgot to make. We continue with our sessions after the anniversary. The next session is on July 6th on the quality improvement initiative in neonatal care. Then we will have one more session towards the end of July by Professor Alan Job. So the next session is by Professor Prakash Sa on 5 QYs in neonatal. Thank you, everybody.
Thank you.